Okay, so good evening, everyone. It's Ednesia presenting, and my presentation is going to be on distension media and intrauterine pressure management. And thereafter, I'll show you, hopefully it will play a video of us, the latest hysteroscopy that we did. So we know that hysteroscopy enables us to visualize the uterine cavity. It allows us to diagnose and to treat intrauterine pathology. And to achieve this, we know that we need a distension medium, which could either be a fluid or it can be a gas. And so when we use this media, it allows us to have a panoramic view of an otherwise narrow uterine cavity. And the intrauterine pressure needs to be needed to adequately view the endometrium. It's actually proportional to the muscle tone and to the thickness of the uterus. And so we know that the refractive index of each medium affects the magnification and the visualization. We know that the higher the refractive index, the less light is going to penetrate, and the lower it is, the more we are able to see clearly. So this just about summarizes my presentation. And we know that we can have either gases, electrolyte fluids, or electrolyte-rich fluids, or electrolyte-poor fluids as the distension media. On the gases, we use mostly, we use carbon dioxide. I meant to research on if we can use any other besides carbon dioxide, but in the literature there is carbon dioxide, and this is used for diagnostic purposes. We know that it's a colorless gas, and I'll talk a little bit more about it in the next slide, but we know that the complications we can have with carbon dioxide are mainly gas embolism, and patients will complain of shoulder pain after the procedure. So what safety measures can we institute to try and mitigate these factors? We can use the hysteroscopic insufflator. And this I highlight so that we are aware that it is not safe to use the laparoscopic insufflator when we are doing a hysteroscopy. It should be a specialized insufflator. Then we can also use the electrolyte-rich fluid like saline or Ringer's lactate, and we can use these for both diagnostic and operative procedures. And the biochemical properties, we know that saline has got water, sodium chloride, and it's isotonic. And Ringer's lactate, in addition to water and sodium chloride, it also has potassium and it has calcium. And the main disadvantage or the complications that we get from using these electrolyte-rich fluids are volume overload. And we know that when we have used about 750 mils, we should be planning to complete the procedure. And by the time we use 2,500 mils, we should be ready to stop the procedure. And then other media that we can use are electrolyte-poor fluid, that's mannitol, sorbitol, and glycine. And sorbitol and glycine can be used for operative procedures. And because they're electrolyte poor or they don't conduct electricity, we can use monopolar. And mannitol is mainly used for operative purposes. We know that mannitol is isosmolar, and sorbitol and glycine are hypoosmolar. The main disadvantages of using these media is the risk of volume overload, which occurs at a much lower volume of about 1,500 mils. So, as opposed to when we are using saline or Ringer's lactate, we know we should be ready to stop this procedure by the time we've used 1.5 liters. So in addition to volume overload, we have risks of hyponatremia and hypoosmolality. And with glycine, there's also a risk of hyperammonemia. And with sorbitol, there's a risk of hyperglycemia because it's broken down into simple sugars. So carbon dioxide, it's readily absorbed. It's easily cleared by respiration. It's got a very low refractive index, and this provides excellent visibility. And it widens the field of view at very low magnification. And then gas easily flows through narrow channels, so it makes it ideal when we're doing office hysteroscopy. And so that's the gas that we mostly use. I've never used a gas as a media distension, and I don't know of any hospital which is offering this at the moment. Then the disadvantage is so we say it's good for diagnostic hysteroscopy because if we want to do operative hysteroscopy, we cannot clear blood from the scope, and above pressures that, like, we know that the pressures we should use are between 40 and 60 millimeters of mercury, and above this, carbon dioxide will cause arrhythmias, it will cause cardiac arrest and embolism. So it's important to maintain the intrauterine pressures within this range as a safety measure. Then the fluids, they have an advantage in that they allow symmetrical distension of the cavity. And there's we are also able to wash off blood, to wash off bubbles and tissue fragments, and this is because of the way that it's designed. You'll notice that when we put in the scope for hysteroscopy with saline, water seeps in through the little pores towards the end or towards the tip. And this is actually a mechanism that allows us to wash off whatever is in front of the telescope. And we're not able to do this when we're using carbon dioxide. And the pressure that we should use is about 75 millimeters of mercury. And we hardly ever need more than 100 millimeters of mercury when we are doing this procedure. And we know that when we use pressures that are higher than 100 millimeters of mercury, this can lead to intravasation of fluid and risk overloading the patient. And the disadvantages, as we've said, we know that saline is miscible with blood, so this obscures the vision when the patient is bleeding. And we know that when a patient is bleeding and we can't see, we tend to use more fluid. And so these increased volume, so we then require increased volumes to be able to clear the operative field. And we know that this puts the patient at risk of volume overload. And because saline and Ringer's lactate have high conductivity, we cannot use monopolar. There's a special monopolar that we can use, but I forget the name. But other monopolar we cannot use because it will, because of the high conductivity. Then we know how we deliver them. We either hang the fluid and it falls by gravity, because it's got low viscosity, and we can also use the cuff. We usually use the cuff, and in the last procedure we used the cuff where pressure is being applied onto this bag. But these systems, they're inaccurate for measuring the exact intrauterine fluid volume, and it's also inadequate in measuring the amount of volume we've actually put in. Then we can use pumps that can be used to monitor the pressure. So these are pumps that are that show the pressure that you're putting in. And this point I've already said before, that we have a perforated outer sheet that is, oh no, sorry, this is different. We have a perforated outer sheet which is used for collection of efflux or media. And so this design would create a laminar flow which keeps the visual field clear. And when we are using hysteroscopy, we can use either a closed system or an open system. In the closed system, the fluid returns to a pump reservoir, so we're able to keep an accurate check of the amount of fluid we've used. When we use the open system, it allows for free flow of the medium to the cervix, and it allows it to be collected into a bag for monitoring. In our cases, I don't think we are actually using an open system. We allow the water to leak. And unfortunately, when we do our hysteroscopy, we sort of have towels being put by our feet to absorb the fluid. And this is inaccurate in assessing the amount of fluid that, or the deficit of fluid that we actually have. So I've already talked about carbon dioxide, and I've already talked about fluids, so sorry, this is a repeated slide. Then another thing that we don't commonly use, so we know that commonly we are using saline and Ringer's lactate, and I'm yet to see anyone who is using, in our setting, who is using the other fluids that I've mentioned. But another fluid which I just thought I'd put in was the Dextran 70, and it's the only high viscosity medium that's available for hysteroscopy. It's a non-electrolyte, it's non-conductive, and it can be used for all types of procedures, meaning we can use it either for diagnostic or operative hysteroscopy. And the main advantage is it's immiscible with blood, so it gives good visibility. And because of its high viscosity, there's minimum leakage to the cervix. You'll notice that when we are doing hysteroscopy, especially when you dilate the cervix, there's a risk that fluid will seep through the sides of the, through the sides of the telescope, and actually cause fluid loss, and it actually precludes you or prevents you from having good visibility. So this is not the case with Dextran because of the high viscosity, and it offers excellent visibility. And however, when we are using Dextran 70, we should prevent absorption of more than 500 mils. This is because with each 100 mils of Dextran 70 that's absorbed, we expand the intravascular fluid volume by 800 mils. And so there's a very high risk of overloading the patient with very minimum fluid used. And it may also cause anaphylaxis, it may cause DIC, and I'm not too sure the mechanism, but I also noted that it causes destruction of instruments. So these are the fluids that I thought I'd mostly talk about, as they are mostly common in the saline. And then this one, I mentioned it because it was also new to me. I did not know that we can use Dextran. Then as I finish, let me just show you, let me just go to one or two videos of hysteroscopies that we did. So in our setting, and sorry, hold on. Okay, I hope this is please confirm if you can see this video.
We can see you in the video.
Oh, why can you see me? I'm not supposed to be sharing my video.
We
can see the video.
Oh no, I'm not supposed to be in this video. How do I stop it?
No, we like it that way. I'm joking.
Okay, so this is an example of hysteroscopy that we did, and here the saline, the distension media was normal saline. It was warm normal saline, and we're using those pressure beds to increase, to distend the uterine cavity. Let me see if I can forward this a bit. I want us to go to, so as you can see what I was talking about, when we are doing a hysteroscopy, because saline is miscible with blood, it tends to obscure, like here, it obscures visibility because especially when the patient bleeds a bit. And this is an example we're getting there of, so this patient had an intrauterine polyp, and we're getting to it now. Okay, so there we see that this patient has a polyp, and in this case, at this hospital, unfortunately, the resectoscope stopped working on us, and the patient thankfully did not bleed that much. So we visualized the polyp, and we actually used a small grasper to then grab this polyp, and we actually twisted, as you would do a polyp that's on the cervix, we twisted the polyp, managed to get it out, introduced the scope again. Okay, so there's the polyp that we're talking about. I'm going to stop sharing. So we actually did, I don't know if you can see but let me just show you another one, 1 second.
Yeah, the video not clear to Ozik. I don't know whether it's me or it's all of us, because I could hardly make heads or tail of where we were going with the hysteroscopy there.
Okay, let me, anyone else, did anyone else see it, or it's just not a clear video?
It wasn't very clear. And there was also a bit of noise from the video itself while we were narrating.
So I don't know if it would be helpful to actually play, because it would be the same video, so I won't play it again. Let me see if I have better luck with another one. But in this case, what I wanted to show you was the uterine cavity afterwards. So I guess it's pointless because you haven't seen you haven't actually seen the polyp I was referring to. Okay, I'm going to try this one. I don't know if you can, is this showing on my screen?
No, not yet.
We can't see the video.
All right, let me try that again. And now?
It's better now. This one
Okay.
looks more clear.
Okay, so this is the patient. I don't know if it makes sense to keep quiet. It's a short video. Again, we're using saline as our media. And what we're seeing there is a patient with multiple endometrial cavity polyps. In this case, we actually had a resectoscope, which we managed to use to resect these polyps. Okay, so here the resectoscope is, we know that it's bipolar. That's why we are able to use saline in this case. Okay. So in this one, my other picture was just of a cleared endometrial cavity, or the endometrial cavity, which was now clear. And so I am done with my presentation. Thank you for listening. Dr. Chamnyonga, are you still there?
Yes, I can hear you, Dr. Zeki. Okay. Are you done with the presentation?
I'm done with the presentation. Thank you.
All right. Thank you so much for the lovely presentation. Now I will open the floor to questions. Do we have any contributions, questions from the floor?
Thanks you, Dr. Zeki, for a nice presentation. Please, if you can elaborate on how, maybe I missed how you explained in terms of monitoring for fluid overload in the patients that you presented.
So in my presentation, I talked about having a closed system and an open system. Where a closed system, all the fluid that you use is taken back to the pump and it's measured. Then in an open system, we've got the fluid collecting into a bag and then being measured. And I actually did say that in our case, the fluid tends to leak. So we actually estimate, so we cannot really accurately estimate how much fluid we have used. So routinely, we try to stop by the time we have used maybe 3, sometimes even 4 liters, because we take into account that most of this fluid is going onto the floor. And I don't know if there's a hospital that has devices that can actually measure the amount of fluid used. So in our case, we are estimating by the volume that we're giving in.
All right. So what do you think of doing checking the electrolytes after your procedure?
If we think we have used too much fluid, I think it must be routine. to check electrolytes, especially if you have used more than if a procedure was long and you've used a substantive amount of fluid. So I think if you have used 3 liters, usually 3 liters and below, there's really no need to check for fluid, because you know that most of it has come out. Most of it actually does spill on the floor. But I guess if you use more fluid than you think you should have, it's important to check the electrolytes after each procedure. And also, I think this depends on the patient. A young, healthy patient probably can tolerate 2-3 liters over 1 hour, but an elderly patient with hypertensive heart disease or other things might not be able to tolerate even that small amount of fluid over such a short time. So I don't think it's harmful to check electrolytes after each procedure.
All right. Yeah, I'm really concerned about having saline or the distension medium flowing onto the drapes, and we have no idea how much the patient has absorbed. So we really run the risk of fluid overload. I think if in that case, is it not possible to even just place probably even a refuse bag just underneath there, so that underneath the patient's bums, so that at least we can collect the fluid that is being lost during the hysteroscope, so that at least we may have an idea of how much the patient may have absorbed, and correct if there's need to correct the overload.
I absolutely agree with you, Dr. Nyakuru. I think that would be good practice. And I also maybe should have checked what the urologists are doing because they do therapies, and it's very similar to what we do. I'd like to know how they manage their fluids.
Yeah, sure. If you can get that and then probably share with the group. Thank you so much.
Okay, Doc.
Dr. Zeki, maybe
Yes,
we can have contributions from Dr. Chuang and Dr. Shava, because I'm assuming that they do also more cases of hysteroscopy. How do they manage their fluid deficit, or do the fluid management? Maybe Dr. Chuang and Dr. Shava.
Evening, everyone. I'm actually just honored to have been mentioned in the same breath as Dr. Shava. But I think that with my fluid management, I just estimate, and I try not to use more than 2 liters of fluid for any procedure. And then when I account for what leaks out, once I'm done with 2 liters, I stop. That's basically my safety net, and I generally use saline.
Thank you, Dr. Shava.
Yeah, the fluid overload problem. Normally, you must remember it's mainly when you are doing operative hysteroscopy, particularly if you are removing things like they were using a resectoscope to remove polyps or to remove fibroids, where the areas that you leave are going to have lots of raw areas. Those are the patients who are at risk fluid overload. And in my what I do for diagnostic laparoscopy, normally once I get to 3 liters, usually by that time, if you were looking for something, you should have seen it by that time. And I normally just get the fluid collected in a bag, and then we just subtract from what we have added. That is just a rough estimate, and it gives us. And the other thing is there are bags that you actually put under the patient's buttocks, which actually collect all the fluid, and then it gives you measurement. Graduations on it. These companies, they actually make these bags where it actually tells you how much fluid. It's mainly related to strand 70. Dr. Ziki, I don't know whether you actually noticed that they say deficit. You must not go beyond 500 deficit. That actually works out to about something like 4 liters, which is actually too much. Normally, you should even exceed 200 mils, because otherwise, by the time you get to 500, you are already. But basically, that's how I measure fluid input and then out. And then, Dr. Ziki, are you still there?
I'm here.
Yes, I think you should have also shown us while you are doing your hysteroscopies. I think you said you did that one a few days ago, isn't it?
Yes, sir.
Yeah, I think you should have also shown us to see whether you were really in the uterus or you created a cavity.
Yes, you're right. I've got photos, though. I've got still photos of those showing the ostia.
Yes, because it's very important, because it's very easy to create false, particularly in a patient who has got a lot of activity like the one you were showing, that it's not very clear. You can actually be in a false tract. So you need to show. The first thing you get in is to make sure that you identify, and then you say, here's the ostia, the rest is pathology. Thank you.
Thank you, Dr. Shaban. Noted. It's just that unfortunately I didn't record this on a flash. I used my phone to record, but I've got still pictures of us seeing the ostia.
Okay.
Doctor, is it important to monitor the pressure, or it's enough to just monitor the fluid?
No, it's very important to monitor the pressure. I think you're supposed to use about 75 millimeters of mercury. Other texts say 80, but I think that's just about the same. But you should not go beyond 100 millimeters of mercury. This increases the extravasation of fluid. So the intravasation into blood vessels. So it's important to monitor the pressure. And with the bags that we use, it can be difficult to know exactly how much pressure you're putting. But there are specialized bags, I think, that actually show how much pressure you've got in a bag. So it's important, whether you're using carbon dioxide or you're using saline or whatever media, you must monitor the pressure.
No, thank you. Dr. Mapang, you have been quiet.
I'm following closely.
It's okay. Do we have questions for Dr. Ziki?
I have got a question. Has anyone ever used carbon dioxide?
Not me.
Yeah, carbon dioxide, I think, well, I also haven't had the experience of having to use the gas. And remember, it just depends on institutions. And I have only heard about people talking about it, but I have not personally used it. I have only met people talking about it in congresses. Dr. Mapanga.
Hi, Dr. Shah.
I'm sure you must have a comment or question. You can't just follow closely.
Not today. Not today. I don't have a question.
Dr. Chamnyongo?
Yeah, I think, thank you so much, Dr. Ziki, for your lovely presentation. It appears as if there are no more questions. Any housekeeping issues, Dr. Shawa?
Hello?
Yes, we can hear you.
Right. We need to get people who are interested in going to write the part ones, and also those who are going for their part twos. We need to get people to prepare those for. I think we are going to prepare towards March. I think we have only. I think Michael, you are going this. This December, isn't this November, is it? Right. So
yes, I'm going on Friday, Dr. Shah.
On Friday, yeah.
Yes.
So I think, yeah. So, but I think Angie, we need to prepare you for. Have you already registered on the platform?
For the part one?
Yes, for the part one.
I'm not sure which registering I did. I did something, the one that you're just supposed to pay the 30 pounds. I haven't done anything other than that.
Okay, yeah. So I think if you have done that, then that's perfectly fine. And then I think other than that, the other things I think we will discuss that in when I think I'm going to give the last presentation on the 14th of December. Then we will discuss if there are any other new things. And then for those who have already written, Felix, Michael, and Taku, you know that I think Taku, your boyfriend, has retired. Yes. So
Dr. Shawa, did you say my boyfriend?
your boyfriend in Cape Town.
Taku, talk to us.
Of course, as my daughter, I can give you to anybody. Clive, I think Clive has retired from the Gezia program. So, but he will still be available for us next year. So it shouldn't be a problem. He has been quite useful in making sure that the acclimatization there is good. And the other thing is those who have got their part twos, I think you must notice that you are now our new mentors. Ne? So you need to actually, Felix, and today it's only you, Felix.
Yes.
We need to make sure that you provide, you are actually, you need to be our new mentors. So I think the Gezia in Cape Town will bring out the appointments very soon. Yes, Taku, I think you have a question.
Yes, I just wanted to say one of the issues with planning for writing is the short notice that we get for registering. It's made it very difficult to plan. I'm not sure if we could have dates early so that we're able to plan well in advance for writing the exams, because for me that was the confirmation for this month just came too late for me to get things in order. I'm not sure if dates can come early.
Yeah, that is an important thingy, and we hope it was actually disrupted during the COVID period. We used to have very, everything used to be well planned, but because of COVID, they kept on chopping and changing, and even in Cape Town, there were lots of cancellations as well. So that's why they were planning almost on a month-to-month basis. But I think next year is going to be completely different, and I think now the curriculum is almost set, so I think it shouldn't really be a problem. But for us, I think all what we just need is we need to be prepared all the time, so that if they say the exam is in 2 weeks' time, you only worry about the money.
Okay, thank you.
Okay,
I
thank you,
think,
Dr. Shava.
Thank you.
I think we can end the meeting. Thank you everyone for attending. Our next meeting, I think Dr. Marere is going to be presenting. We'll share the topic on the WhatsApp group. If there are no more contributions, we can end the meeting. Thank you all.
Thank you.
And good night.
Thank
Bye.
you. Good night.
Thank you.